At the moment, we're using Telehealth, the home hubs for our chronic obstructive pulmonary disease patients. I manage a community team and we've integrated into our service to try and ensure that we can take on extra patients, allow them to be more self-caring and work with us better on what to do for themselves on a day-to-day basis. We've quite a big geographical area, so it also helps us to design who we're going to visit on a day-to-day basis, if we need to visit, if we can just do a telephone consultation, and it just allows us to work more efficiently and effectively.
So are your nursing team positive about it?
Yes and no at first, but now they are. Yeah. When they actually find something positive from it, then they suddenly realise the benefit.
From our experience, the NHS isn't been very quick in adopting the technologies, and we'd like that to change clearly. But we can sense that the need for very strong evidence is what clinicians really need. They need to be absolutely certain that this is making a positive change, because it's a very different way of working. And so we continue to try and persuade all the powers that be that that's what they should be doing.
We have now more than 50,000 patients that use the program or have used the program. We have 15 hospitals that are employing the program or one of the programs, because it is a platform. So we have programs for this whole series, 20 or more chronic indications, ranging from chronic heart failure to multiple sclerosis, from hypertension up to diabetes.
It's really interesting to see how the whole field is developing. Every year there's more work in telehealth. We've heard about a lot of projects that have been set up over the last few years, and it'd be interesting to see how they've developed and whether they're reporting results.
Well, we've had quite a lot of experience with what I call a more complex technology, and then more recently we've started using interactive telephone messaging, and that's what I'm most excited by, because that's affordable and patients are keen on it, and it's the kind of thing you can use in a general practice setting for prevention.
How difficult is it to persuade the patients to take part in this, and also your GP partners?
Well, as far as the patients go, they are usually quite keen as long as they can handle the technology, which if you're using mobile phone texting isn't the case for a lot of people who've got long-term conditions who are over 65. Then as far as other GPs go, I work with about 10 practices at the moment who are using it for hypertension. Then on the whole, they're okay about it, the GPs agree, the burden falls on the practice nurses, and then you've got to help the practice nurses be able to do it as part of their core delivery.
The suppliers are moving into the NHS, but the speed at which they're moving into the NHS is quite slow. So the levels of adoption and the scale of what people are trying to do is still small scale, often based on pilots, and quite limited in terms of impact.
So that's frustrating for the people that you work with, but are you finding that that's necessary for the NHS?
I think you could say that the end of the pilot is probably here. There is a lot of evidence, whether that be randomised controlled trials that we've been speaking about at the conference, or additional evidence to say move forward and progress. The day of doing 100 patients on telehealth is probably over. The benefits only get achieved by moving to scale.
We are working on the evidence at the moment. We are carrying out a large randomized controlled trial. So we have done some studies, and they seem to indicate that the results are good, and that the patient gets some benefits, but also that the hospital gets benefits. But we are working on this, and this is similar to most other telemedicine applications. That this is actually just the moment right now in time where we are really trying to collect data and get information about whether it is worth the while.
I suppose what we're looking at is home monitoring technologies, blood pressure monitoring, oxygen saturation, blood sugar, and allowing that information then to transfer back to our database, back to our GPs. And I suppose ultimately in Ireland we have a huge crisis in our A&Es. Looking at admission avoidance and early discharge programmes is what I suppose what our ultimate aim is.
And are you convinced it is better for patients?
Oh, certainly. There is definitely better. They have access to a triage nurse. That triage nurse is sending that patient to the appropriate service out of hours. We have a tendency, I suppose, in Ireland to call a GP when we should call an ambulance when we should be calling a GP. And it's sending that patient to the appropriate service is what one of our aims would be.
My name is Robert Johnston. I am the chair of a group called Access Matters, which is a very small charity. But through that, I'm also on the board of a group called National Voices, which is a network of more than 200 health and social care charities in England. I think I'm interested not in specific technologies, but the principle of empowering the patient to be able to monitor and control their own health, to hold their own records, to monitor their day-to-day progress, and to really bring that idea of patient-centred healthcare into the health system.
Do you think all patients want that?
They all want it. Whether they realise they want it yet or not is another matter. And certainly the health system should want that, because it's going to be much more cost effective and successful if they can incorporate these principles.
So do you think the clinicians that you and other patients have come into contact with are adopting this as quickly as they should?
Absolutely not. There's a lot of cultural resistance, there's a fear, certainly a caution, which you could actually look at, that somehow the control will be taken away from them. And so there's an institutional resistance, there's all sorts of barriers, silo thinking. You know, the patients can cut right through that.